Hello and welcome to our virtual rhinoplasty meetings. My name is Dr. Cameron McIntosh and I'm the president of SORSSA, or the Society of Rhinoplasty Surgeons of South Africa. So during the coronavirus lockdown period, we decided to have bi-weekly Zoom meetings. We specifically chose teachers from around the world to be able to cover many topics. Unfortunately, due to patient confidentiality, we can't actually show you the real talks. However, the very interesting interactive question and answer sessions is what we're going to be showing you. We want to give a shout out to our colleagues around the world fighting coronavirus. Please look after yourselves and be safe. So I'm not going to say anything more. Enjoy the show. For episode 12, we're moving to Germany to listen to Dr. Wolfgang Gubisch giving us a fantastic talk about the septum in rhinoplasty. Okay, so if the questions can start rolling in. If you want to take the screen sharing away, Prof, then we can, I'm going to start rolling through some of the questions that people have.
I can do that?
Yeah, there we go. That's perfect. Thank you. Okay. So you have 350 people around the world listening to what you're having to say now. And let's jump into one of the first questions that you have is, how do you fixate short nasal bones and what is your taping protocol?
The short nasal bones I cannot reach when I pull back the skin envelope. And therefore I fix them with a TTC suture, which I showed you twice. That means I perforate with a needle, with a cannula, the skin, the bone, the neoseptum, the bone of the opposite side, the skin. And then I bring in a suture, furrow, PDS, and then I lift the skin envelope and bring the ends of these suture inside the nose. Then I do a second cannula and pull it back so that I find inside the nose the opening of the second one. And then I can insert this furrow, bring it to the opposite side, and then I can make the knot. This is a very great technique developed by Sebastian Hack, and you can use it also if you have a very wide nose. In the old days, we used the forecast, the plaster of Paris for 3 weeks and hope that it stays together. With this suture, we don't need that. This brings the things in position. Or if accidentally you make your classical technique and your L-shaped frame breaks, then you have to do something for fixation. This is also a good tool for that.
Thank you. Okay, so 2 more questions from ZS is, what is your taping protocol after free dice cartilage? And how do you harvest ethmoid?
Well, the taping protocol is, I use Cosmopore. That is a fleece which doesn't glue to the skin. And this is fixed with a paper tape. On top of that is a normal sticking plaster, where is also you saw how I make the sticking plaster around. I just press it together and later on I cut it so that when the tip swells, it can open and you will not get pressure marks like I got earlier. And on top of that, there is a plaster of Paris to the nose as well as the forehead and a circular bandage so that I can avoid any influence of the mimic muscles.
Right.
Inside the nose, I don't pack the nose really. I put just these style splints.
Okay, thank you. Okay, Inkensani wants to know, good evening, thank you for the great lecture. How do you avoid collapse of the tripod structure when you combine total extracorporeal septoplasty with osteotomies?
Well, the septum is fixed, the neoseptum is fixed to the nasal bones, to the upper lats, and to the anterior nasal spine. That means these are 3 points. And then if you fix it to the 3 points, it cannot change. It cannot move. If you fix it only to 2 points, of course, there is always the chance of changing and moving, but not in 3 points. The 3-point fixation is the important thing.
Okay, here's a very interesting question from Ernest Moller. He wants to know, what is your choice technique of flap or cover for septal perforation?
I use always the 4-flap technique. That means I dissect the mucosa from the upper lats so that I have a flap which I can bring down. Then I cut the mucosa at the insertion of the lower turbinate. Then I have a bridge flap from the nasal floor, which I can shift medially, and then I have to close it. But there are big septal perforations I cannot close with that technique. And then in all cases, I reconstruct, of course, the missing septum. That means I take from somewhere else cartilage, or I harvest from the ear. But it should be supported by some cartilage graft.
Great. Okay, David Whitehead has a question for you. Wolfgang, what a wonderful lecture yet again. You never fail to impress us all. How do you deal with calcified rib cartilage when you operate?
Then first I cry. But on the other side, I know if I have a calcified cartilage, it will not bend. This is the prerequisite. And then, of course, it is more difficult technically to prepare these strips. But of course, you may need not only one, but different dermatome blades. But in the end, there is no other chance to do that.
Thank you. I just want to remind everybody that for CME points, there is a link to the survey that Amir has just put on in the messages. I'm going to move over to YouTube quickly and ask some questions that have come out from there, Prof. Theodorus would like to know, what kind of suture do you use for the TTC?
4O PDS.
4O PDS, great. And then do you also suture the L strut to the perpendicular plate when you suture the L strut to the nasal bone?
No, I fix it only to the nasal bones, to the upper lats, and to the anterior nasal spine.
Great. Okay. Suleiman wants to know, when you say you take the septum out, do you remove or preserve 6 millimeters to 1 centimeter of dorsal septum?
No, of course not. Then I have only a partial extracorporeal septal reconstruction. These 6 millimeters, this is helpful to preserve the keystone area, and it makes easier to fix it to the residual stump of the septum. But on the other side, in many cases, if you have 1 centimeter, it is difficult to reach it and to fix it there. So for me, it's better then in these cases to take out everything. This means total extracorporeal septal reconstruction, means to take out everything, because then your septum is larger and you have more option to reconstruct a neoseptum with the right dimensions.
Thank you. Enrico says, dear Wolfgang, your cases are surely not the 17-year-old with a little hump. Okay, another question here is from Armani on YouTube, wants to know, Dr. Gubisch, where can we get the metallic cannula for diced cartilage injection?
Send me an email, I will write you, because otherwise I should not advertise any companies. It's made by my company, but you can write me an email, then I will answer.
Thank you. Amir has also put up a link for a little questionnaire that we're running. It's a 2-minute evaluation with 20 questions. So please have a look at that. And then we've got a question from Brian Wong, and a massive shout out to Brian Wong. Brian Wong has put this whole thing together for us. We really, Brian, we are so chuffed with the support from the University of California, Irvine. Thank you for helping us. And Brian would like to know, what is your opinion on preservation rhinoplasty?
Oh, there I should take, that takes too long, but I will make a short comment on that. Preservation technique is a technique where some principles of the technique in some patients are extremely helpful. Specifically, if you have a straight septum, if you have a very thin-skinned patient, then it is always a stick into my heart to destroy the dorsum. But on the other side, it is not as easy. It's not a technique as it is shown for everybody, and the learning curve would be very small. I think it's a technique which needs a lot of experience and especially experience in selecting the right patients. You saw from my patients, there are not too many. And I have honestly to say, I have more complications with the preservation technique than with the classical structural rhinoplasty.
Thanks, Prof. Okay, so there's two questions. It's quite an interesting one. Both of them are to do with how do you harvest the ethmoid, and how do you harvest it without breaking it into little pieces?
Well, the harvesting of the ethmoid is, I try about in the intercanthal line to make a cut in the bone so that I don't just break it with the force of my chisel. There may always the chance that there runs a bad fracture into the skull base. Therefore, I try to make a vertical cut with my side cutting burr or with a big strong scissor about in an angle of 60 degrees compared to the dorsum level. And then you can, the residual part you can fracture with your 5mm chisel, and then you bring it out.
Great. Shah would like to know, when you inject diced cartilage without fascia, can there be chances of disimpaction?
Well, nowadays I almost never use fascia, even if I have to do an augmentation of a huge amount of cartilage. I think this has several aspects. Of course, if I use in fascia, I used always allogenic fascia, because allogenic fascia gives for me better aesthetic dorsal lines. But on the other side, you have a round configuration. There is always some irregularities at the side wall. Therefore, I use exclusively diced cartilage because the fascia works as a barrier. Without the fascia, you have no barrier, so the survival rate will be higher than if you have a fascia in between. Now, Rollin proved already that with the barrier, the fascia as a barrier, these grafts survive. So the survival rate must be even higher and better if you use free diced cartilage. You can mold it better. You have not so sharp aesthetic dorsal lines, but molding is easier. And therefore, I think it is a perfect tool. I started to use it only for camouflaging instead of the allogenic fascia, because allogenic fascia, some people refuse that it's from a dead body and I don't want it. And I don't want to harvest their own fascia lata because you have a cut in a young girl at the outside is not so nice. And the fascia from the temporalis fascia quite often is thin. So Nazim Circus suggested the fascia, if you have take a rib graft, of course you can take the fascia there. That is a good option. But as I said, nowadays for these dorsal sculpturing, dorsal molding, I mostly use only free graft. And then the thing is that you immediately fix it, and you know the plaster of Paris stays always for 2 weeks. After 2 weeks, there is no chance of migration.
Thank you. Eric says, great results. Question is, does the TTC suture go through mucosa inside the nose, and is it an issue for infection?
You should avoid that. But maybe that sometimes it happened, but I never saw a dorsal infection by that, but I try to avoid it.
Great. Okay, Filio, again, asking a question. Thank you very much, Prof. Gubisch. I always learn from you. The suture you use for the TTC suture is for a PDS with straight needle, if I understood well. What type of needle is it? Cutting, a reverse cutting? And is this the same needle that you use when you suture your spreaders with a special forceps?
No, these must not be a straight needle. Therefore, I use a curved needle. And I use for these purposes always sharp needles. Round needles I use only if I have to reconstruct the lower framework. That means the lower lats. If I have to, in the one patient you saw, I use the bending technique to mold these 1 millimeter thick strips of rib cartilage. Then it's essential that you use a round needle. But if I do this kind of work, I use always a cutting needle.
Okay, thank you. Lissandro is back on here. He would like to know, perfect class, congratulations. Have you had absorption problems or infections with ethmoid plates? And what is the post-operative care that you use?
The post-operative care is nothing special. And I had no problems. And there is a study from Charles East from London after 1 year, and he dissected it out in some cases, and he saw that these small bone grafts are not resorbed. And I think they are not resorbed because they are so thin. If you normally use bone grafts, of course, a part is always resorbed. But if you thin them so much as I do, they are pretty thin. You can read the newspaper through these bone grafts, and you have a lot of these drill holes. Then the resorption rate is low, or I had no problems with that. And Charles saw that they survived.
A question from Felipe is, how much DCF do you often use on the Dorton?
DCF? Almost never. Only free diced cartilage.
Okay. Ali Rez, nice to get a question from Ali. Dear Wolfgang, excellent lecture as before and perfect results in these very deviated and crooked noses that I know the correction is not easy. Please tell us regarding your tricks for osteotomies in these patients as question number 1.
Okay. Hi, Ali. Well, as you know, I do always low to low lateral and transversal osteotomies in the intercanthal line, and my paramedian osteotomy is always done with a side cutting burr to remove, not only to cut the bone, also to remove some bone at the same time. And I always do my osteotomies strongly in the nasofacial groove. This is important and essential that you avoid any step deformity. I see so many noses where the lateral osteotomy is too high. And for me, there is no reason to preserve the Webster's triangle. I never saw a problem with that. And of course, you need sharp instruments. This is quite clear. And as you have seen, when I make my step incision, then I take my 3 millimeter chisel and just I scratch on the bone. This is like a glass cutter effect. This is not really, it doesn't make a cut through the bone, but it's such like a glass cutter effect. This is a preformation of my osteotomy line.
Great, thank you. Ali's got a second question, is what is your idea regarding the use of rib cartilage from cadaver or a tissue bank?
Yeah, well, in Germany, it's almost not available. Second, it's extremely expensive. And there are only a few colleagues who are using it often, like Rod Rorich. He was talking about that he is quite happy with that. I used it only once when I operated somewhere else abroad, and they offered me, the working with this cartilage is nice, but I don't know if it really, what is the long-term effect. And of course, here in Germany, the costs are almost 1,000 euros. And that means a nose is 1,000 euros more expensive. And I think in your country, Ali, it is also not easy available. And also the costs are for you and your patients quite high.
Great. We got a question from Dr. Petros, wants to know, a great lecture, Prof. Have you observed and in what percentage infection rates with a PDS foil? Isn't it very tricky to use with a septal perforation closure?
That is very tricky, of course. And that was, I wouldn't recommend it to do that. In my clinical experience, I saw not many problems because it was easy to preserve it. But I did some animal experiments in rabbit noses, because I always worked when I did some studies with rabbit noses. and the skin, the mucosa is there so thin that, of course, I had always perforations. And from all the rabbits where I used it, there's more 20 or 25, no single one stayed in place. All these PDS files and the transplanted cartilage was resorbed.
Thank you. Okay, we've got a question from one of the rising stars of rhinoplasty in the United States of America, all the way from Miami, Paula Fruz. He wants to know, thank you, Professor Gubisch. So the question is, after extracorporeal septoplasty, how far under the nasal bones will you place the new septum, i.e., how much overlap is there?
No, I just place it directly in between. I have the neoseptum with the spreader grafts on each side. The spreader grafts are at the same height like the level of the dorsal dorsal graft, and this is placed directly in between. So ideally, it should be one smooth surface. It's not always so easy to do that, and therefore I need this paste of cartilage to camouflage it.
Great. A question back over to the YouTube. It says from Theodorus, Prof, do you use intermediate osteotomies one-sided or both-sided in severely deviated noses in the bony part? If yes, how do you plan them?
I never use that because it creates only a lot of instability. And if you have such a mobilization, I think it is very dangerous to do also these intermediate osteotomies. I did more than 10,000 noses. I never did these intermediate osteotomies.
Okay, I've got a question here from Ashish. He says, great masterful lecture, Prof. What minimal length do you keep for the dorsal and caudal border while reconstructing the extracorporeal framework?
This is not quite clear, the question for me. Can you explain me what?
Okay, I'll try and see if I can get it right here. What minimal length do you keep for the dorsal caudal border while reconstructing the extracorporeal framework?
I think the length of the dorsum should be about 30 to 35 millimeter, and the length of the anterior border should be 16 to 18 millimeter.
Fantastic. Okay, well, our time is virtually up here. I'm going to let's leave one more question here from Ahmad. I think we might have already addressed it. Is have you experienced any complications in not preserving Webster's triangle?
No, I did not. The problem is always that the people who recommend to preserve it, they are fearing that the head of the lower turbinate is medialized. Of course, you can first have a look to where is the level of your lower turbinate, but I personally had never a problem.
Okay, so Prof, I'm going to ask one last question when we finish this off. You've been doing rhinoplasty for 45 years now. What would be the 3 things, because I know there are many fellows and residents watching this tonight as well all over the world, the 3 most important things with the rhinoplasty that you would give us to say?
Well, it's difficult to say that in 3 or well, I think you have to be able to operate each septum. If you are not able to correct a septum, a severely deformed septum, then you should stay away from noses. Second, function and aesthetics have the same value. You cannot, when I started, they said, well, if you want a nice nose, you have to accept that breathing gets a little worse. This is crazy. And third, you have to be honest. Nobody has only good results, me not too. So you have to be honest, and you have to follow your patients as long as you can. You have to do good documentation. And of course, you should be in a situation where you can discuss your problems, and each of us has problems, can discuss with good friends. These are the prerequisites that you can become a successful rhinoplasty surgeon.
Wow. That's great. That's such wise words. So, Prof, I genuinely just want to say thank you so much from a SORSSA perspective. I know you've been to South Africa many times, and we look forward to having you there again one day. But from the bottom of our heart, thank you very much for tonight. Thank you for sharing so much of your wisdom with us. And thank you to everybody else who's joined us from around the world. We look forward to seeing you all again next Tuesday and next Thursday. Same time, same place. So have a good sleep, and thank you very much, Prof.
It was a great pleasure for me, and best greetings to all my friends in the world. Bye.